Growing up, I knew my parents were there for me. We celebrated family events. They were there for me when I was sick or needed help. As me and my sister grew up, we knew we could count on our parents. We were so proud to be their children. Today, we are there for our parents, to share in the celebration of their grandchildren or to be there when they are ill or need assistance. They can count on us. And now our parents look to us to take care of them. Hello, and welcome to Always There. My name is Michael Wilsker, and I am Vice President of an elder care company called Always Best Care Senior Services. We provide in-home non-medical care for seniors and free independent and assisted living placement. Today my guest is Madeline Prez, and we're going to be talking about hospice care. Madeline is currently Administrator and Clinical Director for Solomar Hospice, located in Auburn, Massachusetts. As a former Director of Nursing and working in a long-term care facility for over 20 years, Madeline brings a wealth of knowledge and experience to the hospice industry. In 2012, Madeline was honored with the Solomar Hospice Administrator and Best Office of the Year award. Throughout her career, Madeline has won numerous awards and accreditations for her dedication to providing quality patient care. Madeline, thanks for being here. Madeline, before we begin, can you just give me an overall definition of hospice?
Sure. Hospice is defined as supportive care meant to care for patients and their family members at the final stages, end stages of a terminal illness. The goal of hospice is comfort. It's not curative. So hospice care is usually ordered and initiated when a physician feels that all curative measures have been exhausted and the patient requires more of a palliative type care program.
So they don't get involved in any other kinds of care other than taking care of the person for their medical condition?
Correct. There are 5 disciplines on a hospice team. The RN, the registered nurse, her job with the hospice team is to ensure that the patient is comfortable and has everything that they need to manage all of their symptoms. So she becomes, or he becomes, the eyes and ears of the physician. The nurse goes in routinely and assesses the patient and makes any recommendations needed for medication management and symptom management and becomes the collaborator with the physician. The goal or the role of the nurse is simply symptom management. One of the other disciplines is the social worker, and the social worker comes in to take care of the patient for psychosocial needs. More time of the social worker is spent with the family than actually with the patient. When a patient is diagnosed with a terminal illness or has demonstrated a progression of a terminal illness, at such time that hospice becomes necessary, the family needs become the psychological needs of the family become more apparent than the psychological needs of the patient. And what the social worker does is help the family cope with the journey and understand what's happening and deal with their grief and their anticipatory bereavement issues. We also have the role of a hospice aide, which is a home health aide on the hospice team. And the role of the home health aide is to provide the personal care for the patient. So that might consist of bathing, dressing, grooming, may consist of feeding if a patient is no longer to feed themselves. Or sometimes the hospice aide is used in a way to give the patient some one-to-one time, doing something that the family members can't be there to do. For example, families can request that the hospice aide not do the personal care, but be there in the afternoon to take the patient outside, to play cards, to do things that bring quality, right? The goal of hospice is comfort and quality of life. So the hospice aide's role can be personal care, but more often than not, especially in the home setting, we find it to be more quality of life type care tasks. We also have a chaplain that's on our hospice team, and the role of the chaplain is to provide spiritual support and and spiritual pain relief for the patient and the family. Again, more often than not, it's the family that requires the support of the chaplain through their grieving process. But the role of the chaplain is to provide the spiritual care. And then we oftentimes have volunteers that are involved with the patient. And the volunteer does not perform any hands-on personal type care, but is somebody else to be with the patient when the family can't be there, to provide some quality of life measures.
How do you define terminal care? Is there a defined definition of it, or is pretty much up to the physician to decide whether or not the care is necessary for hospice?
Well, the regulation, the standard for hospice is the patient, the physician needs to determine that the patient has 6 or fewer months left of their life expectancy in order to have hospice come on board. Now, more often than not, the patients live longer than 6 months. But in order for hospice to be requested, in order for hospice to be initiated, the physician, yes, has to determine and sign a certification of terminal illness, which spells out that the patient, and if the disease ran its usual course, in the physician's best estimate, the patient would have 6 or fewer months left of their life expectancy.
When you talked about volunteers, how do you go about getting a volunteer, and do they have to have any background in caring for people?
Sure. We have a member of our team who is our life care coordinator, and a big part of her role is volunteer recruitment and volunteer training. And so she goes out into the community and looks for volunteers. She places ads, things like in the church bulletins, she maybe with the veterans groups, things like that, places ads for volunteers. You do not have to have any type of healthcare experience. You don't have to have any type of hospice experience to be a volunteer for hospice. The volunteer coordinator does a thorough training with every volunteer who wants to come on and be part of our team. And that training goes into things like signs and symptoms of death, what to expect as disease progresses, how to support families, how to support patients, what to say, what not to say. And most of the time, the volunteers are there to just be another supportive presence. We have music therapists, we have pet therapists, we have art therapists that decide to volunteer with us, and they bring a whole other dimension and a whole other dynamic to our team in helping this patient and their family process their journey or things that they've encountered or things that they're expecting to encounter.
And how much time are they there during the day? Are they there for 24 hours? Are they there for 2 hours? How is that determined, based on their type of illness?
The hospice team or the volunteer?
Well, the whole hospice team.
The whole hospice team.
Right.
The plan of care for a patient is very individualized, and it depends on the needs of the patient and depends on the needs of the family. Hospice does not provide 24-hour care 7 days a week. So in times when 24-hour care is needed, we reach out to other agencies that we can partner with that can be there overnight and be there providing personal care and hands-on care when we can't be there. The typical hospice plan of care looks like a hospice aide usually is with a patient for about an hour or two, 3 to 5 times a week. The hospice nurse, again, depending on the situation and the symptoms that the patient is exhibiting, the hospice nurse can be there from once a week for an hour to 5 times a week for an hour to 2 hours a day. Social worker and chaplain, again, because the care that they provide is more geared towards the family. They do an assessment of the patient and the family, and then they determine. They could be there as little as once a month, or they can be there as often as once a week or twice a week. But again, it's very individualized. As a patient comes on to hospice, usually the plan of care, the amount of time spent is lesser in the beginning of the hospice stay and is more towards the end. As the disease progresses and as the patient becomes more symptomatic and has more needs, the care that's required increases. And so the hospice team increases the amount of time and the frequency that they're with the patient.
So if a physician determines that hospice is necessary, He then talks to the family about whether or not it's the right fit for them.
Correct.
And so it's not mandatory. If the doctor says she needs hospice, the family doesn't have to agree. Is
Right,
that correct?
right.
And what would be the reasons why they would disagree?
Well, sometimes families, there's a lot of myths and there's a lot of misconceptions about hospice. Sometimes we've heard that families think that hospice comes in and hastens death, right? They provide medications that make death happen sooner. When in reality it's just the opposite, right? The sooner the hospice team gets involved with the patient, the better the care is. The hospice team needs to and wants to build a relationship with that patient and build a relationship with that family. And you need to have time to do that, right? So if the hospice team is called in early enough so that there is time where the patient is still alert and able to build relationships, it's such a more meaningful, it's a more meaningful end of life for that patient. If you are, looking towards this hospice team to be the eyes and ears of the physician and make sure your loved one is taken care of, you need to trust the members of that hospice team. And you can't build trust if you don't have time to build that relationship. So many times families, they don't know that hospice is more about promoting quality at the end of life and extending life in a comfortable way. They feel that hospice comes in and hastens death. That's usually the main reason that we hear families are not agreeing to have hospice.
Can the family on their own bring in hospice, or they have to get the physician to sign off on that?
There needs to be a physician's order in place. Usually what happens, the hospice referral process is the family is usually, more often than not, the one that actually comes up with the idea of hospice. As we know, physicians are great at what they do, and they're there to take care of and to cure patients. But when it comes time to having hard conversations with patients and families regarding lack of curative treatment, the need for more palliative care, physicians have a hard time with those discussions. So it's usually the families that bring up hospice to the physicians, and most often it's because they've had a hospice experience with another family member or a friend or a neighbor. So they'll discuss hospice with their physician. If the physician feels that the patient's disease process is at such a point that there are no more curative measures that can be done, they've exhausted all avenues, he or she will agree or disagree with hospice. If they agree with hospice, the family has the right to choose the hospice company or the hospice team that they want involved. And they let the physician know what team they want the physician to reach out to. The physician will then contact the hospice company and make a true referral. Give us the information about the patient, the diagnosis, where the patient is located. From there, the hospice team goes out and meets the patient and looks through the patient's medical record to determine eligibility for hospice. Hospice cannot look at a patient, cannot look at any medical records, cannot even really interact without the physician's order.
But they dispense medicine, don't they? The nurse dispenses medicine, or for pain killing? Nothing of that, so it's all through the doctors?
It's all through the doctors, right. The nurse can make recommendations. So if a nurse goes in to see her hospice patient and the patient's having pain, and the medication and the treatments that are already in place are not successful at managing the pain, the nurse will recommend either increasing the dosage of the medication or changing the medication. The nurse cannot order the medication, the nurse cannot dispense the medication. The nurse has to reach out to the physician and let the physician know what his or her recommendations are and why they're recommending that change, and only the physician has the right to change an order. If the physician agrees with the recommendations, the physician will then contact the pharmacy and provide the order for the medication change, and the pharmacy will dispense the medication.
The pharmacy would, and how would that take place when they say dispensing, or the pharmacy orders provides the medicine, then how is it delivered and taken by the patient?
There are a couple of different ways. If the patient is in their own home and not in a nursing home, and they're receiving hospice care in their home, the families have a choice of whether they want to continue using their local pharmacy like they've always used for medications, or they can use our pharmacy, the hospice pharmacy. If they choose to use their own local pharmacy, any medication changes that are ordered by the physician need to be called into, or a prescription needs to be faxed into the pharmacy from the physician or the physician's office. The pharmacy will then fill the prescription, and the family will go out to the pharmacy and pick up the medication, just like they've always done in the past. If the medication is something that is related to the patient's hospice diagnosis, the family will present a special insurance card, a hospice insurance card, to the pharmacy, so that the pharmacy will not charge the patient or the family for those medications. Those medications are paid for by the hospice company. The family will pick up the medication, bring it home, and then will provide the medication to the patient as they always have. If the family chooses not to do that, or there is not family that's close enough in proximity to do that, the hospice team, the hospice nurse, will order through orders from the physician, will order medication through the hospice pharmacy. The hospice pharmacy is located in Pennsylvania, so it's not just around the corner, so you can't just drive there and pick up a medication. But it gets delivered to the patient overnight by Federal Express. If there's an emergency need for a medication and you can't wait until an overnight delivery, then the hospice company is usually contracted with all the local pharmacies. The hospice nurse could go out and pick up a short supply of that medication and deliver it to the patient while they wait for the full supply to come in from the hospice pharmacy.
And where does most hospice care take place? In the home, nursing homes, assisted living?
It's provided wherever the patient is. If the patient lives at home and the family wants to have them continue living at home with the supportive care of hospice, then the team goes into the patient's home. We do have a large population of patients in nursing homes that we service, and when hospice care is provided in a nursing home, nothing needs to change with the setting of the patient. They remain in the same bed, in the same room, with the same nursing home staff. The hospice staff then becomes an adjunct staff that goes in and helps the nursing home staff manage end-of-life symptoms. We also take care of patients in assisted living. Right? We consider assisted living the patient's home, so we would provide the care just as we would in a private home in an assisted living, with the patient's family and or additional agency services being an extension of us, so that we would train families, we would train home health aides and agency staff to continue to provide the care and symptom management needed when we're not there.
What about in the situation where a patient is in the nursing home and does not want to die in the nursing home, rather go home?
Sure.
Who helps with that decision, and who helps carry out the plan to accomplish that?
The nursing home, the social worker in the nursing home would have this conversation with the patient and the family, and they would determine that the patient wants to go home. They would then, the nursing home facility would then contact the hospice. The hospice team would come out and assess the patient. We would also do what we call a home safety evaluation, where we accompany the family out to the patient's home, and we make sure that the home is safe for the patient to be there, safe for the care team to be there, and we determine the need of any durable medical equipment, hospital beds, oxygen, things like that. We have all of the equipment placed. We collaborate with the nursing home staff to let them know when things will be in place for the transition home. The nursing home staff then arranges transportation, so whether the family transports the patient, or sometimes they'll call an ambulance company to transport the patient. The hospice team and the nursing home team collaborate a date and time for the discharge, and the nursing home team discharges the patient, and upon arrival to the home, the hospice team is already there at the patient's home, ready to transition them and to begin services in the home.
Is there a situation where you have a team put together, they go and work provide care at the house or even the nursing home, wherever, and the patient says, "I'm not happy with this team.
Yes.
I'd like to try another team"?
Yes,
Does that happen?
absolutely.
Yeah.
Just as the patients have the right to say yes or no to hospice, to admit themselves or to admit their family members or to not, they have the right to transfer or revoke their hospice benefits at any time. If that's the case, if they decide that they're not happy with the care, obviously the hospice team that's in there will want to try and work with the patient and the family to limit the amount of change that the patient has to deal with. But if the family is really adamant that they want to change, they have the right to choose the other hospice that they want to be involved. And then it becomes a process where the hospice that's in place collaborates with the new hospice that's coming in to coordinate care, to make sure the new hospice knows where the previous hospice is leaving off. And the family simply signs a transfer form, transferring the care from one hospice to the other. Same thing holds true if they decide they don't want hospice anymore, right? Sometimes patients will be on hospice for a terminal illness, and then they'll decide, I've changed my mind. I want to seek aggressive care. I want to do more chemotherapy, for example. And obviously patients and families have the right to do that, in which case they would revoke their hospice benefit, meaning they would sign off saying that they're voluntarily discharging themselves from hospice to seek aggressive care, or maybe they're just deciding that they don't want hospice. They sign the revocation form and the hospice discharges the patient.
Now, like a lot of people associate hospice just with the seniors, in terminal illness. But hospice also provides care for anyone, regardless of their age, for terminal illness. Is that correct?
Correct, yes. As long as there is a physician who certifies that the patient has a limited life expectancy due to a terminal illness, there is no age limit to hospice. There are certainly hospice companies that specialize, for example, in pediatric hospices, and there are companies that specialize in senior hospices. I am not aware of any one hospice company that takes care of patients at any age, right? You either have the pediatric hospice or you have the adult hospice.
And how do you get paid? How does the hospice, and are they all nonprofit, or are they more for profit? How does that all?
They're both. There are for-profit hospices and there are not-for-profit hospices. Regardless if they're profit or nonprofit, the way that they're reimbursed is the same. There's no difference because of that. For seniors, hospice is a Medicare Part A benefit. So as you age and as a person becomes eligible for Medicare, they're given, so to speak, from the government Medicare Part A, right? They can elect to take on Medicare Part B, which is a cost to them. But Medicare Part A is what pays for hospice. So the government says you're eligible for Medicare, you sign on to Medicare, and with your Medicare comes your hospice benefit. The Medicare Part A benefit pays 100% of hospice services, no matter what setting the hospice is provided in. So if it's in a nursing home, if it's in an assisted living, if it's in a home, the Medicare Part A pays 100% of the hospice care. There is no cost incurred to the patient or the family. In fact, sometimes the family may be able to save on a little bit of expenses if they're privately paying for medications or durable medical equipment, things like that, that the hospice will then provide. That might provide the family with a little bit of savings. Medicaid, Mass Health also has a hospice component to it. So if there is a patient who for some reason doesn't have Medicare, maybe they're a little bit younger, maybe they're not age eligible for Medicare, but they're disabled, so they're on Mass Health or they're on Medicaid. Medicaid also pays for 100% of the hospice benefit. Managed care or private insurances, things like Blue Cross Blue Shield, Tufts, those types of managed care insurances, most, if not all of them, also do have a hospice benefit attached.
Now, we talked earlier about the places where hospice care takes place, but we also talked before we sat down today about hospice homes.
Right.
Can you tell us more about that?
Sure. There are a few hospice homes in the area. It's a new development that will become more prevalent than it is now. And hospice homes are very similar to assisted livings. They look like assisted livings. They provide privacy and a home-like atmosphere for patients who are dying. Hospice homes, unlike assisted livings, only admit patients who are in the final stages of their terminal illness. And what that means is patients who are actively dying. It provides a place for care needs to be met when there's not 24-hour care in the home. They move into hospice houses. There are care teams in the hospice houses that help provide the personal care that's needed in addition to the hospice services that are provided. And it provides a really home-like private environment where the patient can feel comfortable and be surrounded by their families who have access 24/7 to the patient at the hospice house.
Now, I've had personal experience for hospice. My father took ill. He was 83, just passed away a little bit over a year ago. And hospice came in just at the time he was starting to become terminal. And we were fortunate. They were, depending on how you look at it, my father was, he had some very, very extreme difficulties. And we knew he wasn't going to live more than a few months. And just at the time that we determined it was time to let him go, we brought in hospice. And they gave us pretty much the signs of when this was going to happen. And it was amazing, but they were, we were there with my father and, you know, to really say goodbye. But, you know, we asked the hospice, can we come back? And they said, yeah, why don't you go home and take a break? But I do believe that it's imminent. We drove home, and within a half hour later, we got the phone call that my father had passed away.
Wow.
So my feeling about hospice was that they were very upfront. They told us what was going on. They were very there for us, and we appreciated everything that they did for us. I've always felt a warm place in my heart for hospice, the people that provide the care.
That's great.
So we're going to wrap it up.
Okay.
It was very nice to have you here.
Thank you.
I hope everyone who's watching today became a little bit more educated about hospice. And we'll see you next time. Thank you, and have a great day.